It's our honor to present our distinguished guest, Professor Jim Khan. He's Associate Professor of Surgery, Angela Ruskin University. Jim Khan is a specialist colorectal surgeon, a national trainer, and European proctor in laparoscopy and robotic surgery. He will address an important topic about how to train surgeons in minimally accessed surgery. Professor Khan.
Thank you very much, Mr. Chairman, and Assalamu alaikum wa rahmatullahi wa barakatuh. I'm really honored to be here today, again, to talk about training in minimal access surgery. It's a very important topic, and honestly, a big headache for us in Europe as well, because it is changing dynamically as we speak, and knowing the best way to train surgeons safely and competently remains a real challenge. So with my interest in laparoscopic and robotic training and some interest in the work that we have done, I'll try to give you some ideas, and hopefully they'll be replicable in practice in the Egyptian surgical practice as well. So these are my disclosures. I'll cover training in laparoscopy and robotics, some of the challenges in training, more importantly, simulation and modular training, and a UKIP training program. I think there is an interesting dynamics between a trainer and a trainee, and the systems that we work in will influence the end product of all of this interaction, which is training. And we must not forget that at the center of all this remains the patient, and the system, the trainee, and the trainers will work around that, because at the end of the day, that's what we want to do, to get the best for our patients. The new technologies and techniques that come in surgical practice are a big challenge to incorporate into this training matrix, because when new techniques come in, surgeons want to learn it themselves, and then the training suffers, and how to ensure safe training delivery in those situations. There were times when as a surgeon you train and you perform that practice rest of your life till you retire. It is not the same anymore. I have no doubt that I'll be doing something very different in the next 10 years from what I'm doing now. So if I'm not open to change and adapt, it's going to be very difficult to survive. If you look at a surgeon starting from a novice and becoming an expert surgeon, a trainee will go through the state of what we call unconsciously inexpert. So you don't know that you know nothing, to knowing that you're actually an expert. And that pathway is a long journey, starting with the trainee with his awareness or her awareness and motivation, and then paralleled by training, practice, and in fact, perfect practice, and then persistence with that practice. So these are the main pillars that a trainee will have to go through to become consciously an expert. And the role of a trainer in this is that as a trainer, we can persuade the trainees in their awareness and inspiration stage, and we can facilitate the training and the practice stage. Obviously, the first half of this, the motivation has to come from the trainees, but it's easy to blame that they're not interested. We need to play our role to facilitate that. And this is our practice we showed yesterday, that we transformed from open into totally laparoscopic practice and then robotic practice. But this is not the same, or this was not the same in the UK. If you go back in 2005, only 5% of cases were done laparoscopically, colorectal surgery. This is dismal. When we went through a program of training surgeons, and this is an old slide, in 2012, we approached 40% of cases done laparoscopically, which was a big achievement. If you ask me now, it's about 55 to 60%. It's a daunting task. When you start training, it's going to look really, really tough. And we know for sure that if you don't prepare yourself, you're going to perform badly. And we have shown that if you break down your training in any aspect, in sports, in medicine, in aviation, if you perform modular training, you can learn much more quickly and safely. So we had a modular training program in colorectal surgery, in laparoscopy and robotics, and each operation is divided into 5 or 6 modules, and trainees go through them as they progress. And you can see that you teach them in a stepwise fashion, starting with the patient setup and then anastomosis and then exposure of vessels and flexure mobilization and TME in the increasing order of complexity. And once they have mastered all these modules, they can perform the whole operation. This was the program from Department of Health that we ran from the UK. And the model was that you had a steering group with a lead and then training centers in the black in the middle, and then you had a big group of delegates that you had to train. And these were the training centers in the UK that started. Portsmouth was one of those centers. And we trained, in fact, most of the consultants. So 378 training episodes happened in my practice. If you ask me, are there any criteria for a surgeon? When I was growing up, I used to think that to be a surgeon, you need to be very good at basic laparoscopic experience. You have to be a good, gifted surgeon, dexterous with your hands, and you have to be young enough to learn these skills. But actually, to be a good surgeon or a good laparoscopic or minimal access surgeon, you need none of those. What you do need is common sense, insight, precision, patience, and persistence. And that's all just being a surgeon. So all of us will qualify based on those qualities to get trained. This was the traditional training in operating theaters in the 17th and 18th century. This doesn't exist anymore. And there are problems, there are challenges in training. As I said, we have reduced working hours, increased number of trainees to train with limited number of suitable training cases. We had patient expectations going higher. They don't want to be operated by a trainee, and consultants are in the firing line because your results are published. So why a consultant should allow a trainee to do a case when a consultant can perform a better operation? So all these issues really make training delivery a very big challenge for most of us. If I take you back 10 years again, the surgical training in the UK used to be like this. You do 1 year of house officer, 2 to 3 years of a senior house officer, 1 to 2 years of research, 6 years of your specialty training, and then it's a total of 11 to 13 years before you get a consultant job. And the median age when you will become a consultant would have been 37, 38. With 26,400 hours of surgical training under your belt. This is the situation in UK at the moment, and this is from UK. 2 years of foundation, 2 years of core surgical training, 5 years of specialist training, total of 9 years of training. 48 hours per week restriction. They cannot work anymore even if they want to. So 17,280 hours if they don't take any leave or travel away or go on courses. And they all do that. So practically it's no more than 15,000 hours. And that is almost 50% reduction in their commitment to training. How can we train them to the same level as you and I got trained when we were working longer hours than that? Compare that with airline industry. An airline pilot has to do 1,500 hours to get his captain license. And that's total of 3 to 4 years of training. So if an airline can train a graduate to become a captain in 4 years, why can't we train a surgeon? Yes, we can, but that would need changing the whole training delivery pathway. We still think the way we got trained by working long hours, providing service, care for the wards and patients, it has to be the same in this new generation. That's not going to happen. So we will have to think of a way of doing targeted training delivery, reducing the training time, and still produce competent surgeons. I'm going to skip this Miracle at Hudson movie. I was going to play that clip for you. If you have seen Sully Sonnenberger, it's the flight that landed in Hudson after both engines were failed on this Airbus plane after bird strike. And these guys were so calm in this clip. They were really confident. They drilled it again and again and again, and they knew exactly what to do. And it was a miracle that nobody got killed in that crash. We deal with these situations every day in our practice, but how often we prepare our trainees to deal with those, especially if they don't have long hours and experience under their belt. I'm going to skip this, but simulation is come big time in airline industry. This is 1934, the Link trainer. Imagine they were training pilots in simulation at that time, and this is the avionics Airbus trainer now, and they are as real as it gets. Would anybody have an idea how much a simulator of this kind that we are just seeing in the top picture will cost? It's about $20 million. So have we spent that much money in surgical training? No, the answer is no. So you can't expect your trainees to pick up from that simulation. This is a real life simulation of flying a 747, so you can practice everything before you get into the operating room. And that's where the Royal College of Surgeons is going now, because they want trainees to do all this before they get into the operating room. So we might find trainees coming to our theaters who have done 100 anterior resections on the robot in a simulation, and non-practically, and we'll have to then take them through a one live one. And they might have to do 5 or 10, and that's it. In the UK training, in laparoscopy, we have introduced this concept of lap pass, which means that as a trainee, they have to do certain tasks, and we sign them off. It's a passport that they can carry from one hospital to the other. And they can, then if I see somebody with this passport, I know that they have done basic or fundamentals of laparoscopic training. And then you can introduce the next step, which is more advanced training. And then simulation is there, which is becoming more mainstream with the availability of robotics. And you have all the modules on robotic simulators that you can practice, the anastomosis, the division of vessels, mobilization. I must say the technology is not there yet. It's not as near real life as it should be, but it is coming thick and fast, and it's going to get better and better. Cadaver courses, a big resource, very expensive. It's about 2,000 to 3,000 pounds to get a cadaver in the UK, but they give you a near real life idea. I think the anatomy is very similar, and you can perform, this is a transanal resection of a tumor on a cadaver, and this is as real life scenario as it gets. So you can practice dissection techniques, port placement, setup on a cadaver. The problem is the limitation of resources. One cadaver can be used by 2 trainees and then cost significant amount of money, and the availability is limited. So there are real challenges with that as well. We have done studies and do porcine model like a pig model or a goat model in a live situation compares with a cadaver model. Sadly, no. The studies show that it may give you an idea of using the instruments and harmonic and stapler, but actually the anatomy is nowhere near real life. So you don't get a real good feel for performing an operation safely. And then you have enhanced simulation where you can, this is a nephrectomy model on the simulator where you have the renal artery and the renal vein in the top clip, but in the robotic tile profession, you can have a superimposed image of the tumor, the vessels that are feeding into the tumor, and the urologists are using this quite extensively to train their surgeons about partial nephrectomy, for example, or even a total nephrectomy. But these kind of extra aids in surgical planning will help surgeons to train better in a quicker fashion. This is a hysterectomy model on a robotic stimulator, so a gynecological trainee can practice exact steps of robotic hysterectomy before stepping foot into the theater to perform a real-life operation. Learning curve, we talked yesterday very briefly about it, but if you look at a big cohort of 4,800 patients, the learning curve for laparoscopy is not small if you're self-taught. So if you're not taught by anybody, if you're trying to learn laparoscopy, if you look at the QSIM curves, they hit the baseline around 110 Ks for conversion, and similarly 100 plus for complications. So if you use conversion complications as your surrogate markers for proficiency, you need about 100 plus cases if you're trying to learn it yourself. If you're taught by somebody, that learning curve is steeper. So if you have a structured training program, it takes you even less cases. And in fact, there's a publication showing that you need about 20 to 40 cases in laparoscopic training to become safe. And the learning curve is not that huge. When that comes to robotics, that is even halved. Somebody asked the learning curve question yesterday about the robot, and we published on this. You have 2 consoles to train, and you can train in a very safe fashion, and the learning curve for experienced surgeon is no more than 10 to 15 cases in that sense. This is not going to happen. We're not going to have that many trainees in theater to learn from a case. This is a thing of the past. We have to move on with standardizing our operations, performing the same thing again and again so that the trainee get to see the same phenomena, and it's easier for the brain to learn. And the trainees will differ in how quickly they learn. They will also differ in how quickly they learn different steps of the operation. Some steps will be easier than the others. You have to have an assessment form. How do you assess them? Bring some objectivity to it. This is a very good competency assessment tool. We have used it massively in laparoscopy and robotics. And it can assess various performance states along different domains of practice. You train the trainers, train your trainers how best to train your surgeons. And selection of cases, obviously it's common sense. Become an expert. And as I am running out of time, I want you to take you to my last slide, which is the conclusions. And so what a strategy for you, what can work in your system, establish centers of clinical excellence in your country, look at the geography, see which hospitals are the ones who can be good centers, become clinical leaders, then make your mark, do courses, perform master classes, live operating, so that you disseminate the message, and then become the educational centers of excellence, and that model can work very well. I think for trainees in the audience, I would say complete your residency training. So that's asking me to stop. Simulation curriculum will expand. You will have hands-on training and courses and master classes, fellowships in advanced surgery. Video recording is a great tool. Record your cases and watch them again, and you will learn a lot. Adopt a modular training program and have a good mechanism of assessment of your performance. Otherwise, you will never know if you're doing well or bad. And proctoring and mentoring will come for advanced complex cases anyway. Thank you very much for your attention.
Thank you, Professor Khan, for this excellent, nice presentation. Unfortunately, we don't have questions for this lecture. Our professor, Dr. Adil Hosni, allowed for a couple of questions for you. From the floor, if you want to ask him any question, please, from the floor.
I think while they're setting up the next lecture, we can have one quick question if you like.
Couple of questions.
Training is a big problem for us. I think 75% of our workforce is now women and part-time working. So it really has to be robust and spot on.
I have a question, please. Would you mind, can you come over our centers to let us how to do a training and stuff like that in a workshop or something?
Of course.
Can you make this deal now?
No, I would be very happy and delighted to do that. I think most surgeons know how to perform surgery and how to teach and train. What we can share from our experience is a method or a skeleton that has worked for us, and delivering that to leaders from Egypt, for example, will not take more than 5 to 10 sessions. So it's not a big commitment overall, as long as there is willingness from the hosts to run the program. This is
so we do appreciate your coming, and very many thanks for having
you
with
very
us.
much.
Thank you so much. Move to the next plenary lecture.